All right, welcome everyone to room 1. I am Dr. Inge van Balkom. I'll be your moderator for a panel on suicidality and quality of life in developmental disabilities and a talk on non-verbal learning disability. I would like to introduce to you Dr. Jenese October, who will be the first speaker on the panel. She's a child and adolescent psychiatrist who obtained her postgraduate degree from the University of Medical Sciences of Havana. Currently, she works at Georgetown Public Hospital. In her clinical work, she provides services to vulnerable pediatric populations who present to the public hospital. Her ongoing research focuses on neurodevelopmental disorders and suicidal behavior in the pediatric population. Dr. October collaborates with the Global Psychiatric Epidemiology Group and the Guyana Wellbeing Project. She's an adjunct assistant professor in psychiatry at the University of Guyana and core faculty at the local Masters of Medicine in Psychiatry postgraduate program, where she's very passionate about training future mental health professionals. Dr. October, the floor is yours.
Good morning, everyone. It's a pleasure. Oh, I have to see. Good morning, everyone. It's a pleasure to be here with you today to share with respect to the topic of intellectual disability and suicidal behavior. So I have no conflicts of interest. The World Health Organization defines mental health as a state of well-being, of mental well-being, which enables people to cope with the stresses of life, realize their abilities, and learn and work well. So in order for them to contribute to their community, it's an integral component of health, which enables our abilities to make decisions, build relationships, and shape the world we live in. So mental health is a basic human right. So as I was saying, mental health is a basic human right. So it enables us to connect, function, cope, and thrive. So the neurodevelopmental disorders are a group of conditions with onset in the developmental period, and they typically manifest early, often before the child enters school, and it's characterized by developmental deficits that produce impairment in personal, social, academic, or occupational functioning. Next. So intellectual disability is a type of neurodevelopmental disorder, and it's defined by limitations in intellectual functioning, adaptive behavior, with an onset before the age of 18 years old. Next. So these deficits in intellectual functioning can be seen. The patient would have problems with reasoning, problem solving, planning, abstract thinking, etc. And deficits in adaptive functioning are basically evident because the patient failed to meet developmental and sociocultural standards for communication, social participation, and independent living. So a prevalence of 18.3 per 1,000 children being higher in males than in females was actually reported by the Journal of the American Academy of Child and Adolescent Psychiatry in 2020. So 2% of the general population meets criteria for intellectual disability, and they're basically encountered in every clinical setting. There is a 3 to 6 times increased rate of psychiatric and behavior problems in individuals with intellectual disability compared to the general population. So according to the World Health Organization, suicide is a leading cause of death in adolescents worldwide. So for each completed suicide in adolescence, there are about 100 reported attempts. And depression is the strongest individual risk factors. So 60% of depressed young people, have thought about suicide, and 30% would have actually attempted. The incidence of suicide attempts peaked during the mid-adolescent years. So a recent article was done by Shaw et al., which spoke on suicidal behavior and ideation in Guyana. A systematic literature review, which was published in April of this year. And they concluded that the risk groups included males and females, Indo-Guyanese ethnicity, and the most common method that was used was pesticide poisoning. So more specifically, suicidal behavior and intellectual disability. So it wasn't until as late as the 1800s that it was thought that individuals with intellectual disability did not experience the mental disorders seen in the general population. So a lot of diagnostic overshadowing was frequently evident. This was due to a general under-identification of emotional and mental health problems in persons. So behavioral changes were attributed to characteristics of intellectual disability as opposed to mental problems. However, recent research has indicated that persons with intellectual disability actually experience a range of mental disorders, with prevalence rates of psychopathology estimated at 30 to 50%. And in persons with intellectual disability, 11% would have attempted suicide and 23% would have had suicidal ideas. With respect to the risk factors for this specific, in this population for suicide behavior, the literature states and shows that these factors would include the patient having a mental disorder, having a higher IQ, which has been associated with more suicidal behaviors, age being more so adolescents and young adults. Other factors include loneliness, decreased social support, physical disability, chronic medical condition, being female, previous suicidality, history of self-harm, significant life events, loss of a family member, and other factors such as a history of hospitalization, unemployment, and even recent psychosocial stressors. So Bardon et al. From the Center for Research and Intervention on Suicide, Ethical Issues, and in Life Practices in Quebec, Canada in 2020, they basically coined the term of manifestations associated of suicide. It's a term in French, so it basically translates to suicide-related manifestations. And these basically reflect the variety of verbal, nonverbal, direct and indirect behaviors that can express suicidality in persons with intellectual disability. And it's used to identify persons who are at risk. So these types of suicide-related manifestations include thoughts, verbal communication, nonverbal communication, and behavior. So with respect to thoughts, persons with intellectual disability can actually think. Many of them have thoughts of, about their own deaths when it is that they're sad, or they might be thinking about hiding a knife in their room, or thinking about the reaction of a loved one if they're dead or missing. So the thing is that many times these thoughts are not communicated spontaneously. So in that case, it has to be explored. So different methods should be used in order to do this. So you can use clinical vignettes. So in the example that I have here, for example, you can have a picture of someone who's hurting themselves. And along with this picture, you can have a story that goes with it. So for example, in the picture, you can say, well, maybe this person is very frustrated, or they no longer know what to do to change that. Or maybe they would like to stop it. So they would want to, basically they're thinking of dying. So they're trying to find a way to do this. So after you would have given the story to that person, you can then ask them, so how do you feel? If it is, do you feel like, for example, that person who was in the story, what are your thoughts? What do you feel like? If it is that you actually feel like that person, do you still feel this way? If it is that they don't feel that way, why is it that they might not feel that way? So basically, if it is that you do not look for these thoughts in this population, they can actually be missed. With respect to verbal communication, so they can either be direct or indirect. So with respect to direct, it's common, it's similar to that that's found in the general population. So they might say things like, I want to die, or I want to kill myself, or I have dark thoughts. Indirectly, which is more typical for this population, they might say things like, I want to join my grandmother at the cemetery, or I would like to be dead, or you would be better off without me, or I want to go far and not come back, or I want to go with the birds, or I want to act like, you know, someone who might have attempted or would have completed suicide. By text or social media, they can also put statements or even ask questions or put pictures or images or even like posts about death and suicide. So nonverbal communication can include things like drawings, which can represent a violent act or a suicide gesture, drawings of graves, of suffering, of objects to commit suicide. And they might even mimic strangling themselves or cutting themselves or even stabbing themselves. So with respect to behavior, we can have self-aggressive behaviors without injury, or with injury or death. So without injury, some might try to push a non-cutting object, for example, a piece of wood, into their abdomen, well, the skin of the abdomen, arm or leg, or they might swallow pills or non-toxic substances without knowing the potential danger that they have, or try to strangle themselves with their hands, or even holding their breath. So with injury or death, they might swallow pills or substances knowing that, you know, they're actually toxic, might injure themselves with sharp objects, or even strangle or hang themselves with a belt, a towel, or a rope, jump from a window or a high place, jump in front of a vehicle, even jumping into water knowing fully well that they might not be able to swim, or even jumping without even looking, or even crossing the street knowing that, you know, they should. So Burden et al. Also identified observable indicators of suicide risk. And these basically indicated change from base functioning. So these clues can actually help persons to identify those who are at risk, who may not verbally express distress or suicide ideas. So these are the different domains that they would have identified. So cognitively, the person might have difficulty concentrating. And remember, this is a change from someone who would have been functioning in a certain way, and now you would be seeing these changes. So they might have difficulty concentrating, they might be confused. Emotionally, they might now have mood swings or be a bit irritable, might have anxiety, anger, manifestations of sadness, loss of acquired capabilities, for example, regression. It could be someone who might have been toilet trained, and now what we're seeing is secondary enuresis or encopresis. So behavioral changes, they can either get better or worse. So someone who was previously very hyperactive or so, now we might notice that the person is very calm. Or we might have amplification of usual challenging behavior. So aggression, self-injury, temper tantrums, they might be screaming a whole lot more and even have more disruptive behavior. Increased substance use or compulsive behavior, isolation, and even increased requests for help. So somatically, we might see emergence or worsening of physical and digestive symptoms. So they might start complaining of back pain or headaches, etc. Neurovegetative manifestations may include deterioration of sleep. So we might have insomnia, but we can also have these patients having, or these persons having hypersomnia, meaning they're sleeping a lot. With respect to their appetite, they might have loss of appetite or now might have an increase in appetite. And even their energy levels might be altered. And signs of hopelessness would include, for example, negative disclosures about the future. They might be very much, at this point, discouraged, very self-critical. If it is that they're using treatment, they might refuse to actually use it. And if it is that they were or are, if it is that they have help, they might actually refuse that as well. So in conclusion, persons with intellectual disability do present a high risk of suicide behavior. And this suicide behavior can manifest itself in a number of varied verbal and nonverbal ways that can make it difficult to identify. So we need to look for changes because the person might not be able to verbally indicate this, and it can be indicated through their behavior. So once it is that we would have indication of this distress, it must be explored, understood, recognized, so that an appropriate intervention must be done. Thank you.
Okay, then we go on to the second talk of this panel, which will be done by Dr. Sigrid Piening. Dr. Piening is a senior researcher and social worker at the Young's Department of Youth Mental Health and Autism at Lentis Psychiatric Institute in the Netherlands. Her research focuses on issues related to autism, including topics related to epigenetics, screening, gender, behavior, and sensory processing. Dr. Piening has published work on Marshall-Smith syndrome and Malan syndrome, rare genetic syndromes associated with autism phenotypes. The floor is yours, Dr. Piening.
Thank you, Inge. Let me see if I can get my presentation on the screen. Oh, wait. I'm not really used to working with Zoom. We're always working with Teams. So let me see. Probably now you have.
Yes, it's there.
Yeah.
Yes.
Is it in? It's
slides? Not in presentation mode,
No.
but in slides. That's okay.
Oh. Yeah, I'm not really. I don't think I'll be able to do it in the
presentation
full,
mode.
yeah.
Okay.
So
okay.
Let me. I tried just now, but let me do it. Make it a bit bigger.
Yeah,
and
that's
then
bigger.
Hopefully, everyone can see just a bit better. Okay, like this. Well, thank you for your introduction, Inge, and thank you for the opportunity to present here today. I'd like to tell you about our exploration of suicidality in a Dutch autism spectrum disorder or ASD population using innovative language process and natural language processing methods. I have no conflicts of interest to disclose. And this study is a part of a larger project, the Elucidating Female Autism Study or Emphasis project, that was supported financially by the public Dutch funding organization ZonMW. And I'm presenting today on behalf of our Emphasis project team, consisting of several researchers and clinicians, of which Inge van Balkom, our moderator today, is a member as well. Rick Opdam, Olaf Gruppen, and Rico Montelet are also heavily involved in this study. And throughout the project, we collaborate with experts by experience of our sounding board, who advise us on each study of the project. But before I continue with the ins and outs of the studies, first some information from our national organization, Statistics Netherlands, on suicidality up to 2020. In this graph, you can see the completed suicide rates for men in the light blue line, for women in the dark blue, and the total numbers are represented by the green line. Suicide rates are consistently higher for men than women, so no surprises there, I guess. And you can see that the rates for men and women follow roughly the same patterns. The rates are currently approximately about 10 per 100,000 persons, which is about 1% of all deaths in the Netherlands and relatively low compared to many other countries. Yearly, approximately 94,000 suicide attempts are recorded in the Netherlands, of which 14,000 people are admitted to hospitals. So how do these numbers compare with the situation in Guyana? You might be familiar with this graph from the World Health Organization, consisting of pre-COVID data of 2019. I'm not sure if you can actually see this, but for the Netherlands, our tiny country in the blue circle, the numbers are in the second lowest suicide rate category, whereas the numbers for Guyana are unfortunately in the highest category. So back to our emphasis study and the autism spectrum disorders, or ASD. For those of you who might not be too familiar with ASD, I'd like to give a short introduction. So according to the DSM-5 criteria, ASD is considered a developmental disorder. People are born with ASD and it's hereditary. And the main symptoms of ASD have to do with deficits in social communication and interaction, and repetitive behaviors and restricted interests. And sensory sensitivities and insensitivities can also be present in people with ASD. I'd like to stress the spectrum aspect of ASD. Presence of these symptoms can differ significantly between individuals. And comorbidities such as intellectual disabilities, but also anxiety, depression and suicidality, etc., are often present, but not definitely not always. So in the specialized ambulatory care center where Inge and I work, for example, about 60% of our population has one or more comorbidity. It's estimated that ASD occurs in 1 to 2% of the population, of which the majority is male. And according to a review by Sigrid and Upthegrove, I hope I pronounced this correctly, 72% of people with ASD have suicidal ideations, and suicide attempts occur in 7 to 47% of the ASD population, depending on how it's been counted or recorded. And there are quite some risk factors for suicidality, specifically for individuals with ASD, of which I want to highlight 3 for this presentation specifically. That's comorbidity, self-harm, and being bullied. And I'll shortly mention addiction as well. And I'll come back to these aspects in a few slides. So our current studies are aimed at exploring our database, specifically on symptoms of our patients and their medication. And we're looking into this because we think tailor-made intervention might be needed for women and men separately. And today I'd like to show you some of our very, very preliminary results, specifically related to suicidality. So our population consists of service users with ASD of all ages and intellectual levels in our specialized outpatient clinic in the Netherlands. We included files of almost 1,500 service users, of which approximately 40% were female and 56% adult. And we used innovative natural language processing methods to identify symptoms and medication from free text files in the electronic patient files, such as intake reports and progress notes that are recorded over a longer period of time. And with this natural language processing method, we're able to uncover way more information about our population that otherwise would not pop up from the more easily retrievable tick boxes in the files. And as symptoms vary over time, that cannot be captured by extracting the information from those tick boxes at a certain moment in time, because those histories are not recorded. And knowing about this history is specifically necessary since waiting list for treatment at our facility is currently almost up to 2 years. And unfortunately, our organization is not the only, is not the exception in the Netherlands. So getting to know our population better as a group facilitates interventions that might reduce those waiting lists. And the natural language processing facilitates training of an algorithm that identifies certain words as possible symptoms. And for this, initially we manually devised a set of symptoms on which the algorithm automatically continues to add more potential symptoms. And symptoms with spelling errors were automatically included. Symptoms that were actually not present but mentioned anyway. So for example, my colleagues can record that someone does not have sensory issues. And those cases are excluded, as well as symptoms that might belong to family members. We're looking into that currently to see if we can make this work. And on the preliminary data I'm showing you today, we performed descriptive statistics, chi-squares and odds ratios. So first, some results on the comorbidity. One of the risk factors for suicidality. As I mentioned earlier, about 60% of our population has one or more comorbidity. In the subgroup of service users that have medication mentioned in their file, comorbidity was even occurring in 92% of service users. And addiction and ADHD were more prevalent in boys and men. Trauma, depression and eating disorders were more often seen in girls and women. So this word cloud is a first visualization of the data on symptoms in our database. The bigger the words, the more often they're found in the files. It is in Dutch, but it'll still give you a nice impression, I guess. And as you can see, the algorithm identified quite some symptoms. And for this figure, I even deleted the symptoms that were recorded less than 10 times. And what also becomes clear from this figure, well, to me that is, and to Inge, is that several versions of the same words can be recorded separately by the algorithm. For example, the words boos and boosheid can be combined into one category, namely anger. So from here, we still have quite some data cleaning and categorization to do. But I thought it was nice to show you this already. And after a first quick and dirty clean and categorization session, I made this top 15 of most prevalent symptoms. So by combining these different versions of the same word, such as boos and boosheid, into anger, anger was actually the most prevalent words with almost 38,000 hits in the database. Tension and anxiety were the second and third most prevalent. Depression holds the 5th place. But words related to self-harm and bullying, also risk factors that I mentioned earlier, are in this top 15 as well. So continuing to pharmacological treatment, we observed medication in 43% of the patient files. And in this figure here, you can see the percentage of the medication groups that were recorded for men and women, separately for children and adults. And what we can see here is that antidepressants were mentioned most often for both women and men. This is a bigger picture. I'm not sure if you can read all this, but I'll try to talk you through it. Because here you see the odds ratios for several individual medications and their medication groups for women and men. So the medication with the blue dots that are on the right of the red line. So for example, this one, I hope you can see where I'm pointing right now. These indicate that this specific drug or drug group was more prevalent in files of women. And I've highlighted the antidepressants in this figure since they have the most immediate link with suicidality. And for example, let me see, fluoxetine over here and paroxetine are examples of medication that is more prevalent in files of women, while fluvoxamine over here was observed more often in files of men. And this indicates that sex differences in medication possibly do exist in our population. Again, stressing that we have to do some further refining analyses. So what can we learn from this? Well, I can't stress enough that these were very preliminary findings. We definitely have to do some refining of the algorithm and further cleaning and analyses to assess our data. That being said, I do think we can cautiously say that probably differences do exist between sexes if it comes to medication. And comorbidity often occurs, especially in the group with medication in the files. And suicidal thoughts, self-harm and bullying are definitely present in our population. And we have to look into this further before drawing up recommendations for tailor-made interventions in clinical practice. So in conclusion, it appears that this population is especially prone to several risk factors for suicidality that might not have emerged if we were looking only at comorbid depression diagnoses in the electronic files. And well, this concludes my presentation for today. I'd like to thank you for your attention, and I'd be happy to answer any of your questions at the end of this session. Thank you.
Thank you, Dr. Piening. If there are any questions, please save them. At the end, we'll have 5 minutes. Dr. Bresnahan is a member of the Global Psychiatric Epidemiology Group, where her research expertise is focused on longitudinal studies, including multinational collaborative research with complex data requiring harmonization over time. She is the mother of an adult son with autism and has devoted many years researching the topic and advocating for him and others with the condition. She will be speaking on quality of life, and Dr. Bresnahan has taught core courses in epidemiology and research methods and is a co-investigator on the Columbia University of Guyana Research and Injury in Trauma Training Program and the Guyana Wellbeing Study. Go ahead, Dr. Bresnahan. Yes.
Good morning. Thanks for having me. Today I'm going to talk about quality of life and hopefully convey the centrality of this concept in the arena of intellectual disabilities and in a conference focused on suicide. I have no conflicts of interest. Quality of life is something that we intuitively understand. It's about an individual's perception of their life. There are dozens of different definitions for it, but I posted here the WHO, and it's a subjective satisfaction with your own life within the context in which you live. This is a universal human concern. Everybody strives to have a higher quality of life, or a good quality of life. And this is extremely true in vulnerable groups, where it may be a step towards understanding their lived experiences and why it might be different. Sorry. The intellect, we would think that the quality of life as an able person for the intellectually disabled is lacking, or at least from an objective standpoint. They're victimized, impoverished, frequently socially isolated and excluded. They have smaller social networks. They're not independent in many instances, and they're not treated with respect frequently, and maybe even worse. And yet their life has value, and they value their lives. And many report a high quality of life. And they get that, but they still get that their life can be better or not. So why we're bothering is that the quality of life presents a framework for us to assess the personal outcomes. What is for individuals with intellectual disability. It allows us to identify targets for policy interventions and planning. And it provides a measurement of outcomes for program evaluation. The quality of life framework also highlights how at various levels, an individual quality of life can be affected. It can be affected by various levels. So at the microsystem level, these are things within your personal scope of control or influence. The mesosystem would be things that are attached to specific local environments that you're in, organizations, schools, organizations that provide handicap services and so on. And at the macro system level, these would be, at the larger societal level, things that are really less controlled by you in the extreme. But they may be controlled by persons in your environment. Assuming that we can agree on what the components of quality of life are, there are a bunch of, it's like a nest of problems in terms of measuring quality of life. Do you ask, is the respondent, given that they're disabled, that they're intellectually disabled, are we going to ask them, or are we going to have a proxy answer for them, or both? Individuals with ID might have been influenced by other factors. Inga has the best example where an individual with autism followed the pattern. When they were when they were giving the responses, they actually replicated a pattern that was visually pleasing to them. And this would be, the kind of misclassification of quality of life that you might expect. There's cultural and environmental specificity. There's item specificity for a given condition. The meaning might change if you have autism or mental retardation, or autism and mental retardation. And it changes over the age of the respondent, so that your perception of your quality of life based on where you want to be might be different when you're 10 than when you're 50 or 70. A 10-year-old might want more cartoons and feel disappointed that they're not getting them. A 50-year-old might want to stay inside more. So and it's also there's also the issue of subjective and objective measurement of quality of life. Do we take an objective measurement based on what our personal or our cultural beliefs are, what constitutes a good, high quality or a good quality of life? Or do we follow the subjective sense of a high quality of life, which pertains to the individual? Most of the things that I'm going to be talking about are based on individual subjective quality of life. I'm going to discuss the first widely known, it's not the first one that I'm going to discuss is a widely known scale or conceptualization of quality of life by Shalek. And it reflects the degree to which people experience things, they have experiences that are of value for them. Those experiences occur in domains contributing to a full and interconnected life. They occur in the context in which they are involved, and they involve events that are common to the human experience. According to this model, quality of life is considered a desired state, I'm quoting, of personal well-being that is universal, has universal and culture-bound properties. It includes both objective and subjective components and is influenced by individual and environmental factors. This model has been validated across different cultures and communities. And this is it. It's got, it has 8 domains. 1, 2, 3, 4, 5. Yes, 8 domains. I'm sorry for counting them. And the domains correspond to different constructs that are related to the kinds of things that contribute to high quality of life. But they, in a sense, they are overlapping. So you won't be able to clearly distinguish. I mean, you can, but it's hard to clearly distinguish as a newbie social inclusion and interpersonal relationships, although there's a large sector that overlaps. So personal development, can you take care of yourself? And are you continuing along those lines? Hold on a second, I'm getting my it's personal competence, education and your performance, your successes and achievement and productivity. So that's over here. And interpersonal relations, those are interactions that you have, your social networks and contacts, your relationship supports. Social inclusion is a community integration, community roles, social support. Self-determination is autonomy and goals, personal values and choices. Physical well-being is your health and activities of daily living, so that overlaps again. Social inclusion, I did that. And rights, human rights, I like that one. It's respect, dignity, and equality, your legal rights, and all the things that relate to being a human and having the equivalent rights of other people in your community. Emotional well-being includes safety and security, your contentment, your self-concept and experience of self-worth, and lack of stress. Your physical well-being is your health, activities of daily living, and leisure, recreation, and hobbies. And the one that have material well-being is financial status, employment, housing, things that you would expect. How do you live? The next is the WHO quality of life, which is has different domains, but there's general agreement about what the domains that are significant for people who have intellectual impairments. And then they've created disability modules so that there's a disability module that goes with the WHO. And in addition, there's been one that's been created recently that has to do with autism. So then the question is, why are we even talking about this, even though we have this great framework? You know, the fact is that when you're thinking about suicide, and the high rates of suicide in the intellectually disabled, you can, one of the real problems is that there is such pressure on their pressure downwards in terms of quality of life. And these are not nimble people who can solve problems necessarily, and get them, you know, and remove themselves from circumstances and to actively engage and improve their quality of life, although they can advocate for themselves. So that's one aspect. And then the other is that we should always remember that quality of life for the intellectually disabled who are adults, they want to experience an adult status. So they want the kind of human dignity that comes from being an adult. And while you're imposing, you know, or when you're developing programs and interventions and policies and so on, you need to recognize that and include the voices of individuals with disabilities. While I was doing this work for this talk, I want you to know that nature sustainability is talking about quality of life on different, you know, in different planets. So, you know, I think that we can do here on Earth that we can manage our own quality of life and help and not resist the efforts of facilitate and not resist the efforts of the intellectually disabled in developing their own quality of life. And this
Thank
is
you. Yes. Thank you,
so
Dr.
much.
Bresnahan. We'll keep questions for the end, but I would like to first now have Dr. Fisher introduce Dr. Fisher. She's a research scientist at the New York State Psychiatric Institute and associate professor of clinical psychiatric social work in the Department of Psychiatry at Columbia University College of Physicians and Surgeons. Dr. Fisher's expertise is in the development, validation, and implementation of assessment methods for mental health conditions in childhood and adolescence. She's widely acknowledged in the field at large as an expert in assessment issues, and she actively collaborates with investigators both within the Department of Psychiatry at Columbia and at other institutions. She will be explaining to us nonverbal learning disability, what it is, and efforts being made to get it included in future DSMs.
Of course, now I have to know how to announce it. Okay, so the alternative title is Getting NVLD into DSM as a neurodevelopmental disorder. So these are my thanks. I will say that most of this work has been funded by the NVLD project, and the main mission of the NVLD project is to get into the DSM. So they have paid for part of this work, not all of it, because I'm underpaid, and I don't have any other conflicts that have to do with it. So I'm going to talk a little bit about what NVLD is, because people don't know what it is, a little bit about the DSM process and what we're doing. So basically, when you say nonverbal learning disability, most people say, oh, they don't talk, which is exactly what it's not. It basically comes out of the world of learning disabilities, and most of the learning disabilities that have been in the literature are verbal learning disabilities, particularly reading. And so this was used to describe it as something that wasn't a verbal problem. So it's a nonverbal learning disability. And the big father of it's Brian Rourke. And so basically, it's people who have problems in the nonverbal aspects of life. And typically there's some sort of perceptual, spatial problem, and it's been defined in a lot of various ways. And the way people used to always define it is that you would have what's called a VIQ, PIQ split, that you're much stronger in verbal, but you're sort of not good at the performance part. Or in some studies, you're a great reader, but you can't do math. or you talk early, but you just like can't get it together, etc. Some definitions have used sensory motor problems, executive functioning problems. But really, the real problem with nonverbal learning disabilities, there's not an agreed definition. And what's required to make a diagnosis, you hear it, actually, sometimes it's called NLD rather than NVLD. So Cornoldi, who's from this Italian group that does a lot of research in it, sees the overlap of it with a lot of the neurodevelopmental disorders, with autism, developmental coordination disorder, other learning disabilities, because you can actually have a learning disability and have this, anxiety, depression, etc. But it's never been really clearly defined. And in fact, individuals with a visual spatial problem currently can't be diagnosed in DSM with a visual spatial problem. They can be diagnosed because they can have a lot of other problems, but there's no DSM disorder that characterizes youth with a visual spatial problem. And in DSM-5, when they went from DSM-5 to DSM-4 to DSM-5, they removed the learning disorders NOS. So what would happen is a child would come in to be evaluated, and they can read and their math might not be great, or they could do this, but they have something that's in effect affecting with their learning. And they used to be given learning disorder NOS, and now that's not there. But what they did at the end of the neurodevelopmental chapter is they have two sort of NOS type things. They're using the other specified and other unspecified. But what they say in the paragraph is that you can't meet the criteria for any of the disorders in the chapter. Well, given that all the neurodevelopmental disorders overlap, so these kids could have ADHD, and technically, if you're being really obsessive, sort of like I am, you think, oh, they can't meet the criteria. So it's been sort of a problem. And why is it important to be in DSM? DSM obviously is not a perfect system, right? But it is how people get reimbursement for services. And it's often used as a textbook, even though it's not not written for one. Like in the class that I teach in the social work school on psychopathology, we go over the DSM diagnoses, and that's how people recognize what a diagnosis is, how they read the literature. Another reason, if you have this other problem that's a big problem in your life, it's not recognized, you would have an incomplete diagnostic formulation, because it's like you have this other thing, but it's never included in anything. And also, I mean, from our point of view, and probably selfishly, it would improve the research to have a standard definition, because any research you see on it, they're all using their own definition. So there are a lot of reasons. But so what happened is the NVLD people came along to Columbia. They're really interested in this, and they didn't know how it worked. And I have been involved in some of the DSM-5 stuff as an advisor, and I was really familiar with how it works. I sat in a lot of these meetings. I'd seen how people did proposals. So I was asked to come to a meeting, and I came along and I said, well, this is what you need to do. They sort of listed how you get something in, which is pretty hard. But first of all, you're going to have to give some evidence. And, like what do we know about it? It was a completely new area to me. I had a nephew who had been diagnosed with it, so I sort of know a little bit about it. But this is not sort of my area, but I did know how to put diagnostic criteria together and sort of how to think about it. So we undertook this long literature review, and we searched everything. So we got like 3,000 articles, and then we had to read a lot of them. We threw a lot of them out, and only 61 made the cut. So it had to be empirical. It had to have an NVLD group and another group. So there's some sort of comparison. It had to be in a peer-reviewed journal, not a review article. They had to actually do a statistical analysis that we could look at. And then, so we got the definitions, we rated them all in terms of quality and summarized the findings. So we found out there were just lots of different definitions. So it's really hard to sort of put all the research together, and people are using a different definition. Sometimes they included motor coordination, social functioning, etc. And everybody said, too bad we don't have the right good definition. But the other thing that was pretty abysmal about it was the studies were terrible. You know, of all of them, we did this whole rating, and I will say we were pretty lenient in our ratings. And we said 8 studies are pretty good, some were fair. But the big problem was they had really small, unrepresentative samples. And often it was hard to see where these samples came from. And there was no blinding of the assessors, there were problems with measures. And, you know, a big problem was a bulk of the studies were middle-class white Americans or Italians, you know, who went to like, who knew, you know, it was just a problem. And actually, a lot of the stuff that's known about NVLD is coming out of people who've had these long neuropsych evaluations. So it is a certain, you don't know about other populations. So we got the literature, and then, you know, we said, well, you know, there's no definition, so we should come up with one, because one of the things that you have to have in DSM is a criteria set. And so, you know, and also the DSM is a manual for clinicians. It has to be in the right format that any clinician, typical clinician, could look at it and use it. And so, and we needed help from sort of the field of NVLD. And so what is a DSM definition? Well, it's not saying you have to give the block design. It's not saying you have to use specific tests. It has to be something that, you know, sort of anybody can understand. And so we went through a long iterative process of putting a criteria set together. We invited NVLD experts. We had our literature review. We had Michael first who could tell us what a DSM definition looks like. We had these 2 in-person consensus meetings with the experts. And then later got, and we had Columbia faculty who were interested in sort of related areas. And then we had a second meeting that was expanded, where we got well-known people in child psychiatry, because it's not the NVLD people who are going to be sitting on the DSM. It's not the true believers. It's the other people that you have to convince. So we got feedback from them. And the first decision that I made at the very first meeting was, you got to change the name. Nobody knows what this means. It's nonverbal. I mean, everybody says, oh, they don't talk. And I kept saying, it's like saying anorexia was like non-fat. I mean, it just didn't make sense. And it was really confusing to people. And given the name of their foundation, it took some convincing. And then between the meetings and after the meetings and other work we did, we sort of followed the DSM process. So we had this little group, like a DSM committee. And then we kept going back and forth, and I would notice something, well, this doesn't really work, and then we understands this. Numerous meetings. It was sort of like running it like David Schaffer had run his child committee, where we're sort of sending things out and getting ballots, you know, and stuff like that. And then we also got some stakeholder opinion on our name change, because we did come up with a name change. So this is the advisory group. These were all people well known in the DSM and the NVLD committee. And these were the people in our scientific council. So you can see some autism people, some ADHD people, some other neurodevelopmental people. And we came up with a definition after much, much work. So, and what we did in the definition is we limited it to deficits in processing and integrating visual spatial information, right? And then we came out with sort of like an ADHD, it's these things. We had the different domains. It had to be present in the early developmental period. We were heading for the neurodevelopmental chapter. We named it developmental to get in the chapter, visual spatial problem. We allowed comorbidity, because most of these things do have comorbidity. So you could make it in the face of somebody who had autism. A lot of the thing with when I first got into this, less so now, that people thought, oh, it's just Asperger, it's just a kind of autism. But it's not. I mean, there's been a lot of research showing that they're different than people who have autism, although you can have both. And so we sort of wrote a DSM definition, and what isn't in the so here it's what it looks like up close. persistent deficits. So, you know, the neurodevelopmental disorders have to be persistent. We came up with 4. Why 4? Well, frankly, a lot of the DSM 4, 5, whatever, were pretty arbitrary when they started out, right? And then they start working. And so we're testing it to see if it works. We gave lots of examples. So this is what it looks like: deficits with orientation, navigation, construction. We have lots of examples in the text. Visual spatial memory, visual spatial scanning, tracking, space. So basically we reviewed the literature and saw what everybody was saying, and fighting with or getting advice from the thing, like, you know, from all the things, are we really covering it? And of course, like anything else, you're probably missing something. And the same way with depression. I mean, people who are depressed don't only have those 9 criteria. There are other criteria, but they're just not in the set. It had to be present in the early developmental period, had to cause impairment because the DSM diagnosis is impairing. And it's not accounted for by intellectual disability or all these other things. So it's not just somebody who, you know, has a low IQ. And that it had to be based on a clinical synthesis of all the information. And if you have reports, it's nice. You don't necessarily have them. And you can make it in the presence of other disorders. So, and this took a really long time to get. It's like herding cats. So basically what we didn't put in it was that you had to have good, strong verbal abilities. Because we sort of thought, like, if the person couldn't do this, would you say they don't have this? Because what happened is a lot of the NVLD things came out of people who their kid was pretty verbal, and maybe even talked early and can read and stuff, and then they just sort of aren't doing well. And the visual spatial thing is coming out. And so they take their child to get a neuropsych test, and then they see that they have problems in this area, right? But there are a lot of people who maybe had problems in this area and weren't, you know, they didn't see the discrepancy. Can you say that there aren't kids who would have this discrepancy who didn't get these tests? And we also didn't include like the known problems like these kids have, like, you know, with autism and everything, you see a lot of anxiety. You see a lot of sort of coordination problems. So they aren't part of the autism diagnosis, but they are common impairments. And so what we did do is we put them in the common impairments by the time we got to the 10th iteration. In the first iteration, they were in the definition, but they came out. And so they're associated features, and we allowed overlap. And from the beginning, we knew we weren't going to get it in the main book. I mean, that's like impossible. So we were going for section 3, which is the part where you ask, you know, you put a criteria set out to encourage more research. And although the people who were funding this were disappointed, I said, there is no way you are ever going to get this right in the book. And so I finally convinced them that that was what's going to happen. And so, you know, the way you get it into section 3, although it hadn't been developed when we started doing this work, it's the same thing to get into the book, except it's like attenuated, like you don't have all the information you need. And so we have this long formulation, this long proposal. It's on the website, what you have to do. And the first thing you have to do is, why do you want to do this? You know, you have to justify it. You talk about the historical context and everything. And so our sales pitch was, why is it important to have this in? Well, first of all, we've pointed out the gap in the system, that, you know, they have neurodevelopmental disorders about attention, and they have them about language, and they have them about verbal, but they have nothing about visual spatial, you know, for kids. And this can cause problems. And that these kids used to get a diagnosis, but now they don't get a diagnosis. So we wanted to give them a diagnostic home so people can know more about them, et cetera, et cetera. So we made a pitch for it, and that, you know, diagnostic formulations are incomplete, and actually it can affect how you treat people. So if you're doing, cognitive behavior therapy, you have to have this imaginal thing and you're not really good at doing that, you might not do that, So stuff like we made a big case about why it was important and how it can improve the system. And then, you had to do benefit to harm. I will say, like, I'm working obviously with a group who really wants an end and true believers, but there is the other side. Like, why do you have to diagnose everybody and say they have a disability? And frankly, one of the people that was being proposed to be in the expert review committee or on the board said, I don't think this should be in the DSM. Like, why does everybody have to give a kid who's just like not good at something a diagnosis? So there is, could it cause a harm? Are you overdiagnosing people? I don't think you probably are, if you have to have impairments. And
excuse me, Dr. Fisher, are you nearing the end of your presentation?
I'm trying to hear.
Okay, all right, go ahead. Okay,
so, but this is what was interesting. One of the things that came at the conference was there was to do a survey, like who are these people who have MBLD? And so, and we should ask them what they thought of the name and see what other problems they have. I mean, are they all going to have autism really? Are they all going to have another neurodevelopmental that like a single one that's going to capture them? So we did these surveys. I'll just get to, it was pretty interesting. We did this survey about parents about their kid. And again, most of our kids were white, which I expected. But in terms of neurodevelopmental disorders, most of them had been diagnosed with a neurodevelopmental disorder. But it wasn't one neurodevelopmental disorder. Some of them had ADHD. And I think a lot of the ADHD cases actually have the inattentive type. And I think some inattentive ADHD people probably have this. They weren't diagnosed with autism, although the males were. They had some coordination problems. But what was even more interesting to me is the high rate of other disorders they had, which is similar to when you look at an autism group, that they tend to have a lot of anxiety, depression, some OCD. They don't have substance problems. They do have, the suicide attempt rate was about 8%. They had a lot of an SSI, etc. So they are, and in our survey, and again, the people are identifying, they're talking about their kids who have been identified as having MBLD. A lot of them have been psychiatrically hospitalized. So it's not like, at least if it's getting the same people who relate to this diagnosis and think they have it, you're not picking up people that are pretty well. So I don't think it's a real problem. But the big bear is with the validators is like, given there's no research on DBSD that we're calling developmental visual spatial disorder, so you have to look at the NVLD research. But even the NVLD research has very little on family aggregation, cultural figures, priors. And I know because I've read it all at this point. There's some later stuff and some cognitive stuff, functional impairment. So it's in gray. It's not marked out, but it's not strong evidence. And, there's like little smidgens of things that can support this. So what we did, and the other question is, can somebody use it? So what we did, and people do like the name. So what we did is we submitted a DSM proposal with everything we had, right? Our beautiful criteria set, writing our beautiful proposal and everything. And then we came in May, we got back in July, and they said, the criteria look nice, they look understandable. This is interesting. But they said, has anybody ever used this criteria set? And they're right, nobody has. And so we're doing a vignette study that's similar to what they did for the ICD, where we're having clinicians use our criteria and rate vignettes. And it's designed so you really have to think about the criteria. We have near misses, we have cases that overlap with autism and have a little NVLD or DVSD, people who have DVSD and have a little bit of autism. So we're looking at people's ability to use the criteria. And then we're going to do a real world study where we're having people use our criteria in clinics. We're continuing to follow the research. And if it gets accepted, and I suspect it will, at least for section 3, you know, it'll be up there for public comment and people will weigh in on it. And we're preparing papers that talk about the consensus process, and particularly to get the criteria set out so people look at it and write up the survey. And that's what we're doing.